Hello, everyone, and welcome to this month's Nutrition Meetup. This month, we are talking about women's health and hormones, and really specifically honing in on the postmenopausal changes that occur. So if you are not postmenopausal, then, we can always discuss that another time. But I know that most of our patient base is, so we're going to really focus on what are those hormonal changes that occur after menopause, and how does that influence our chronic disease risk and our nutritional needs, our lifestyle factors, and so many other variables. So we're going to talk about some of the key hormones for women. We're going to cover androgens, which are what would fall into like the category of testosterone and some of the other similar hormones. We're going to talk about estrogen, progesterone, this hormone called IGF-1 or insulin growth factor and its relationship to different chronic diseases, and the hormone insulin. So let's get into things. You probably are familiar with the term menopause. It's much more common than the term andropause, which is what men go through. But menopause, really the definition is just you haven't had a period for 1 year. So oftentimes for those of you that have already gone through, you probably know things start to get more irregular and then eventually you just don't have a period. And so technically after 1 year of no period, that would be menopause. There's also labs that can confirm it. That's technically not diagnostic criteria, but it is something that can kind of double confirm menopause. And that would be looking at elevated LH or luteinizing hormone and or elevated FSH or follicular stimulating hormone. These are hormones that come from our brain that talk down to the ovaries to make estrogen and progesterone. So when these are elevated, it basically shunts the ability for your body to make more of that estrogen and progesterone. Essentially what's happening is the brain's trying to get the ovaries to make more, but the ovaries aren't responding. And so that's why those hormones become elevated, is because the ovaries are no longer making estrogen and progesterone like they were before. So let's first start off talking about androgens. So androgens is like this class of hormones. Within that, like I mentioned, you've got testosterone, which most people are familiar with. But then you also have these less commonly known hormones, which are things like DHEA and DHEAS. DHEAS is just the sulfated form. So it basically just has what's called a sulfur atom attached to it. You've got androstenedione and DHT or dihydroxy testosterone. DHT is a metabolite of testosterone. So it's about 3 times more potent than testosterone is. So a lot of times when there is elevated DHT levels, you're going to see a lot more of these androgen type symptoms. Now, some women, they experience a drop in androgens during menopause. Other women experience a increase, maybe not in total hormone levels, but in free hormone levels, which we're going to talk about here, the difference between that in a second. These are probably the one hormone that doesn't just shut off across the board. Estrogen and progesterone come primarily from your ovaries. So once you ran out of eggs, those are pretty much shut off. But you can make androgens from your adrenal glands, which are these 2 little glands that are located on top of our kidneys. And actually, most of your androgens come from there. Only a small amount comes from your ovaries. And so that's one of the reasons why you can still make quite a bit of these hormones even after menopause, because only your ovaries are impacted through menopause, right? Your adrenal glands aren't impacted. So sex hormone binding globulin is this protein that binds up the amount of testosterone and estrogen in our body. So one of the things that happens with menopause is that you don't necessarily start making more of these hormones, but your sex hormone binding globulin levels drop. And so when that happens, more of these hormones become available. And so it can present with a lot of high testosterone type symptoms, even though maybe the actual hormone levels haven't changed because the sex hormone binding levels have dropped. I know that's a little bit confusing. So don't worry too much about the specifics of that. We'll talk about what those symptoms might look like, but sometimes this is why you might be like, well, all my labs look like my testosterone's been normal, but you are noticing more of those high androgen symptoms. So what are those? Those can include facial hair growth or whiskers. This is a very common symptom for women as they get older, and you might have friends that have experienced this. oily skin or even adult acne. Sometimes people are like, I've never had acne all my life, and all of a sudden now I'm dealing with acne. Androgenic alopecia, which you might be familiar with. This is basically just a fancy word for hair loss on the head that is driven through high levels of androgens. So androgens cause women to go bald on your head. They also cause men to go bald as well on the head. And they also cause you to grow facial hair growth. So hair in unwanted places, unfortunately. So generally we kind of see this as a similar to like male pattern baldness pattern to where you're going to lose hair on the sides generally. And that will typically start to, get thinner, and then eventually your hair falls out. And this can be because there's high levels of testosterone or that DHT hormone. And then weight gain in the belly region. Now, sometimes this is a hard one to determine because there's a lot of other hormonal causes in menopause that can cause your weight to shift into where more of your weight storage happens in the abdominal area. But androgens are one of those causes. So generally in your reproductive years, your childbearing years, that's when you store more of your body fat on your hips, your thighs, your lower body area. And then once you go through menopause, because of those hormonal changes, a lot of times women's legs become thinner and more of that body fat storage happens in the middle section. And that's because of these hormonal changes that are occurring, and testosterone is one of those that can contribute. Some women can experience low androgens though. And oftentimes women that had low androgen levels before menopause are typically those that are going to deal with more low androgens after menopause. So it really is variable in terms of what happens to your androgen levels after menopause. Some of these symptoms, again, there's crossover with some of the other hormonal changes. So that's where like testing them can be helpful, because then we can actually get a metric of, is it the testosterone that's causing this, or is it low estrogen? Because a lot of times those hormones mimic each other. But symptoms like low libido, low sex drive, lean muscle loss, so like losing muscle at a significant rate, feeling low energy and low motivation, bone loss. Again, this can also be due to low estrogen and progesterone, but testosterone is a contributing factor to things like osteopenia and osteoporosis. Or you might even get like a DEXA scan done that shows your bone mineral density has declined. Those can be indicators into this. Vaginal dryness, again, this can also be attributed to estrogen, but testosterone is a contributing factor, and sleep issues. Testosterone does cause sleep issues when it is low because of its relationship with the adrenal glands. So how can we support our androgen levels? Well, a lot of this starts in perimenopause, and unfortunately, a lot of women don't know about it, but it doesn't mean it's too late to start on this once you've gone through perimenopause and you're in menopause. But the number one thing we really want to work on is managing stress hormone production. One of the things that we know about menopause is that the nervous system is more reactive. So what that means is that something that may have not stressed you out very much when you were 25 or 30 is going to stress your body out more at 55 or 60 because of the hormonal shifts. And so we want to be really cognizant about the way that we're managing our stress, the way that we're supporting our adrenal function. If you're having hot flashes and it's already been a couple years since you've gotten through menopause, it's not a low estrogen issue. It's because of this adrenal hormone change that's occurring that's causing you to have those hot flashes. So hot flashes after going through menopause for a couple of years can most often be a symptom of nervous system dysfunction. So where the body's kind of getting into that fight or flight state, that high cortisol, that high stress hormone type state. So we really want to work on ways to be able to get the body out of fight or flight, and whatever that might look like for you, it's going to differ for each person, but being really cognizant about not being in a chronically high stress or high cortisol state is really important, because your adrenal glands not only are solely responsible for hormone production now that your ovaries aren't making any, but they also are where stress hormones are made. So we're asking a lot of these two little glands that aren't used to having so much responsibility, right? So we really need to give them extra love and nourishment. Resistance training and eating adequate protein are both really important, especially if you have low testosterone. Resistance training helps to be able to stimulate testosterone production. Protein is really important for keeping testosterone levels up. So, somewhere around maybe 2 to 3 days per week of resistance training and making sure that we're getting in about a gram per pound of body weight of protein total per day. So it should be about 30 grams of protein or so, about 3 or 4 times per day to be able to get there. Is going to be really important. Your protein needs increase as you get older. And you'll see that as we talk today, I'm going to stress protein a lot because of that. And then DHEA could be a supplement that DHEA levels decrease with age, and DHEA is the precursor to testosterone. So if you're dealing with low DHEA and low testosterone levels, this can be a really easy supplement that you can take to be able to help mitigate some of those symptoms that you're experiencing. I always recommend testing first to know that there are low levels of these before starting on it, but that can be something that we can also recommend through Fullscript if you're set up there for supplements. So this just shows you hormone changes throughout a lifespan. This is looking at estrogen and progesterone. Testosterone's not on here because, like I said, some women it goes up, some women it goes down. But you can see estrogen is the purple, or I guess the maroon line, and then progesterone is more of that like lilac, lavender type color. And you can see that, as you're going through reproductive years, your estrogen's kind of just like up and down, up and down. Progesterone has these like big highs and lows. And then when you go through perimenopause, we see a lot more pulsality with estrogen, which just means that there's a lot more fluctuations. And with your progesterone, we see a lot more declines in progesterone happening. And then once you've had that last period, now we see very low, almost non-existent levels of both estrogen and progesterone. Progesterone gets impacted more than estrogen, and that's because our body fat can also make estrogen. So we do get some contribution of estrogen from body fat, and unfortunately, only the ovaries can make progesterone. So with estrogen, it's important to know that there's actually 3 types of estrogen. So the main one that we're talking about with menopause is called estradiol. That's the most potent estrogen in the body. It's the main one involved in your reproductive years. And that's the one that drastically changes with menopause. Estrone is a weaker estrogen, and it actually becomes your main estrogen. It's produced primarily by body fat and through that androgen hormone, androstenedione. So some of it comes from the adrenal glands, and some of it comes from body fat. There has been research they've looked at women that actually have higher body fat tend to have less issues, less symptoms during menopause because they have more body fat to help make more of this estrone. Doesn't mean that we're condoning having a higher body fat, but it just shows you the power of body fat for estrogen production. And then estriol is really only made during pregnancy, so it's not really something you have to worry about during menopause. But it's generally just low during menopause because you're not pregnant, right? And it's also a very weak estrogen, so we don't really care about it very much anyways. Well, how does estrogen impact us? In a lot of different ways. And unfortunately, this isn't talked about very much, but estrogen impacts our brain. And we know that when estrogen levels decline during menopause, this is part of why women experience more depression, more cognitive decline like dementia and Alzheimer's, is because there's adequate levels of estradiol. It impacts the heart. When estrogen levels are low, your risk for cardiovascular disease increases. Your cholesterol levels increase, your LDL levels increase, and you've probably seen that show up in your labs as you've gone through menopause because of that drop in estrogen. Your blood sugar increases. Estrogen helps metabolize sugar. So you might notice your fasting blood glucose or your A1C increase as you go through menopause because of that phenomenon. I mentioned cholesterol. Your bone mineral density decreases. Estrogen is really important for bone, so is testosterone and progesterone, but particularly estrogen. And so without much estrogen on board, we can see low bone mineral density occur. Metabolism can drop. Estrogen is important for how we convert the food we eat into energy. And it's also important for our mitochondria, which are where energy production happens. So you might experience more issues with like fatigue when estrogen levels are low because of that. It also is important in vaginal function. So we can see issues with vaginal dryness, vaginal atrophy, vaginal infections. So things like bacterial vaginosis, yeast infections and such. all of those become more prevalent whenever those estrogen levels are low. So I know I just showed you a bunch of different ways that estrogen, when it's low, impacts us, but it's not about dooming you into, okay, now there's nothing we can do about it. It's more so understanding this is how that hormone impacts all these different body systems. Now that we know that, how can we support the body so that we still feel well and everything is functioning as optimally as possible in the body? And there's a lot of things that we can do. One of those, again, is resistance training. Resistance training is one of the best things you can do to be able to support your bone mineral density as your estrogen levels drop, and to support your ability to improve blood sugar control, metabolism, fat metabolism especially. So if we're resistance training consistently, it helps offset a lot of those issues that occur as estrogen drops. By shifting to a higher protein and a lower carbohydrate, meaning less starches and less fruits in the diet, we can work with the drop in glucose metabolism. So I mentioned that estrogen is really important for blood sugar. And so as we have less estrogen levels, we tend to have more issues metabolizing carbohydrates. And you're going to see that reflected with your blood sugar increasing, A1C increasing because of that. Adding in walks after meals can be really helpful to offset some of that as well. It can just be 10 to 15 minutes after you eat, or for 10 to 15 minutes after you eat, and really within the hour after you get done eating is really a great way to help kind of take some of that pressure off your body's ability to metabolize. Incorporating anti-inflammatory foods and supplements. These are things like salmon, sardines, curcumin or turmeric, ginger. Making sure we're not eating a lot of pro-inflammatory things as well is really important, because with this low hormone state, it actually puts the body into a low grade state of inflammation. So we know that menopause and andropause, what men go through, both come with a low level of inflammation in the body. So we want to be constantly thinking of ways we can combat that inflammation with some of the foods and potentially even vitamins that we're utilizing. And then again, making sure that we're really mindful of our stress control, because remember, those adrenal glands now are where all those hormones are being made. So we want to make sure that we're really cognizant of things that are driving up that cortisol that could be impacting these adrenal glands. Okay, progesterone. It begins to decline in perimenopause, as I showed you on that chart. And it's only produced after ovulation. So if you're not ovulating anymore, you're not having a period, you're not making progesterone. But even if you are still having a period, if you're going through perimenopause, you still could have low progesterone levels, because just because you're having a period doesn't mean you're ovulating. They're two different things. They often go hand in hand, but it's not a guarantee. Symptoms of low progesterone include anxiety, sleep difficulties, a drop in thyroid hormone levels. So you might see issues with like hypothyroidism occur, shorter and irregular cycles, or even heavy periods. This is generally more so for perimenopause, when those progesterone levels are declining, but you're still cycling. Bone loss. Progesterone is also important for your bone, and a change in fat storage. So progesterone is part of how that body fat starts to kind of build more in that abdominal section. But progesterone kind of across the board, we call like the chill hormone, because it's really important for sleep, anxiety reduction, and just kind of like helping keep you balanced with the effects of estrogen. So how can we work with these changes in progesterone levels? Well, we know the progesterone impacts sleep and relaxation, and it particularly does this through something called GABA production, which is a neurotransmitter. So we can use sleep support that actually supports GABA production. You can actually take GABA itself, or you could take precursors that help us make more GABA. These are things like L-theanine, which is an amino acid. It's also found in teas, magnesium, valerian root, and ashwagandha. Valerian root and ashwagandha are both adaptogens. So they help with the stress response as well. But they also help with the GABA production. Do you need all of them? Probably not, but they could all be taken together if you really feel like you need extra support here. But I might start with maybe doing, 2 or 3 of these and see how that influences your sleep. Resistance training, again, you're going to see that show up as well, time and time again, because that's really one of the best tactics through menopause. And then making sure that we're consuming adequate amounts of minerals. Minerals are really important for our adrenal function. So these are things like magnesium, calcium, potassium, phosphorus, selenium, molybdenum. And you can simply do this by eating a very diverse plant-rich diet. If you're eating a lot of different types of plants like legumes and nuts and seeds and vegetables and herbs, you're going to be getting in quite a bit of minerals. Sometimes we need extra support, and that's where using something like a mineral supplement could be helpful. And those are things that we can send you over on Fullscript if you feel like that's something you might need support with, or if you feel like maybe you're not getting enough of through your food sources. Okay, let's talk about IGF-1. IGF-1, again, is insulin growth factor. It's important as you get older because we kind of want to make sure we have just enough and not too much. And that's because high levels of IGF-1 are linked to cancer. So as one of the reasons why we go through menopause and andropause is actually to prevent things like cancer. It's our body's way of trying to prevent that, because if we were to stay in a high hormone state, if you were to be having a period for the rest of your life, it would actually be more of a position for something like cancer to occur because the body's constantly in a growth state. So it's actually a protective way, a protective mechanism by the body. So high levels are linked to things like cancer, but low levels are linked to things like type 2 diabetes, osteoporosis, coronary heart disease. So we want to have just enough and not too much, right? Because we don't want any of these issues to occur. But we know about IGF-1 is that people that have lower levels typically live longer. They typically live healthier lives. They have less chronic diseases and typically have lower rates of cancer. So the big things that drive up IGF-1, one of them is going to be being in a hyperglycemic state. So having dysregulated blood sugar, having a high A1C, having a high fasting blood glucose. It's one of the biggest things that drives up IGF-1 because it drives up insulin levels. So we want to work on incorporating things that are going to help with our body's natural blood sugar control. Again, going back to the importance of resistance training, but also making sure we're doing cardiovascular exercise. We want to have both in the mix because resistance training helps increase IGF-1. You can see just by as much as 67%. If you add in what's called creatine monohydrate, which is a particular supplement, it's found in animal products particularly, so like meats and such, you actually get about a 78% increase in IGF-1 levels. But low intensity aerobic training decreases IGF-1 levels. It's not as significant as the increase you get from resistance training, but it's important that we have both because, again, we don't want the things that come with the low IGF-1. We don't want the things that come with high IGF-1. So we can pulse them. We can do a couple of days of resistance training per week, a couple of days of cardiovascular exercise. Maybe that's like running, incline walking, cycling to be able to get the best of both worlds. We also can implement fasting periods followed by high protein periods. We know that when you are in a fasted state, your IGF-1 levels decline dramatically. And that's one of the benefits of long-term fasting. You're not going to really get that from like a 16-hour intermittent fast. We're talking about like a 24-hour or multi-day fast. So for example, a 24-hour fast per month or doing what's called a 4-day fasting mimicking diet resulted in about a 10-fold decrease in insulin levels and a 45% reduction in IGF-1. So this could be a strategy that maybe you do once per month to be able to help keep those insulin growth factor levels low. And then all the other days of the month, we're making sure we're getting an adequate protein to be able to support everything else that we've talked about so far, making sure we're making enough testosterone and that we're supporting our lean bone density and our lean muscle mass and all of these other factors that we want. So it's all about a toggle, right? Of not too much, not too little, but really creating these environments that are going to both support both ends of the spectrum. Creatine, you may or may not be familiar with. Like I mentioned, it's naturally found in animal proteins. So like beef, pork, eggs, all naturally contain it. If you're vegetarian or vegan, you're probably not getting in nearly enough creatine. But generally, we're getting in about 1 to 2 grams per day through our diet, and we need about 3 to 5. So supplementation can be helpful. But these are just some statistics as to what it can provide as you get older. There's been quite a bit of research on creatine and aging populations. And not only just as it relates to that insulin growth factor, but also you can see here in improving bone mineral density. So creatine plus resistance training results in a greater increase in bone mineral density than resistance training alone. It's also been done a lot of research with brain function and higher creatine levels being associated with improved neuropsychological performance, so better cognitive function. It's also been shown to help with cognitive processing, especially if you are sleep deprived, and helping individuals that are aging improve brain function too. So it can be a really great tactic for a lot of reasons, for helping support the IGF-1, helping with bone mineral density, and helping support your brain function as you get older. Insulin. Insulin is our blood sugar hormone. So it's this hormone that's made by our pancreas, which is part of our digestive system, that comes in after we eat to pull the carbohydrate that you just ate out of the bloodstream and into places like your muscle, liver, and your brain, most of it going into the muscle. But we need insulin. We want it to be very sensitive to where it responds very rapidly and it does the job it needs to do. But many individuals that get older struggle with something called insulin resistance. And what that means is that it's not sensitive. It's not doing its job. It's kind of like burned out, right? It's like if you were burnt out from work. That's essentially, it's still there. It's still alive, but it's just not really doing what it's supposed to do. And this can be really problematic as you get older because it can be the precursor to a lot of different metabolic and hormonal and cognitive and chronic disease related issues. We know that skeletal insulin resistance, which is one of the biggest factors that relates to insulin resistance, naturally occurs with aging. So it's just a natural thing that happens that we can only change so much of. We know that individuals that have lower insulin levels live longer. They live healthier lives. And we see that with like centenarians, people that live over 100. They've been shown to have lower insulin levels than people that die young. Higher insulin levels lead to a greater risk of obesity, diabetes, Alzheimer's, heart disease, and other chronic diseases, not to mention are also going to lead to more issues with things like weight gain, fatigue, memory loss, so on and so forth. So it's not just about the big fish, right? It's also about, okay, how is it impacting your day-to-day function and your quality of life? And insulin plays a really big role in that. So I mentioned that insulin naturally starts to work less effectively as you get older. And so again, we want to work with these changes. We know that that's happening. How can we support the body in mitigating some of the effects of that? Well, we talked about earlier just working with reducing carbohydrate intake, really making sure we're getting an adequate protein, but also making sure we're prioritizing things like vegetables and healthy fats. Those really should be the priority of your meals. And unfortunately, you look at a lot of these like senior communities and things and what they're feeding elderly population, and it's all carbs. There's no protein, there's very little vegetables, there's no good healthy fats. It's all refined oils. And it's so the opposite of what the body needs when it gets older. And I also think that a lot of the messaging out there for older people is that maybe you don't need protein because you're not as active. But protein has nothing to do with that. I mean, it does impact our muscle, but it also is the main factor of our immune system. It's a main factor of our bone. So many other things that actually start to get compromised as you get older. So we really want to be thinking about shifting your meals to where they're less focused on things like rice and potatoes and breads and cereals, and more focused on good quality proteins, vegetables, healthy fats, things like eggs and fish and poultry and avocado, nuts, seeds, olive oil. These are really where the priority should be within what you're consuming. We want to look at implementing periods of fasting overnight or between meals. I recommend, on a nightly basis, at least 12 hours. If you can or want to work up to 16, you can. But I think 12 hours is essential. So that would be, if you ate dinner at 7, you're not eating again until 7 the next day. And then making sure you have a couple hours between when you eat throughout the day too, because we want to make sure the body has enough time to be able to bring that hormone insulin back down. You could also consider doing the 24-hour fast or the 4-day fasting mimicking diet, maybe once per month, as a way to be able to help support more of the insulin growth factor levels. And if that's something you're interested in, we're happy to help kind of walk you through what that looks like. But that can also be a really helpful tactic for this. Adding in short walks after meals, it actually reduces glucose by about 10%. And if the glucose is lower, insulin is actually lower. It has to work less hard. So those can be a great way. Eat a meal, say you eat lunch at 12, you go on a walk at 12:30 for 15, 20 minutes. It doesn't have to be anything extensive, but the more you can break up that movement into short bursts, the better. Resistance training regularly, I would say somewhere around 2 to 4 times per week is a really good, starting place or like a really good goal to set there. You can also use things that help with glucose control. So apple cider vinegar has a compound in it called acetic acid that's been shown to help lower the post-meal glucose response. And that can be something you do like 2 ounces of, maybe with a little bit of water to dilute it so it doesn't burn your throat. Drink that right before you eat a meal, and that can be a great way to help. It doesn't work for everyone, but it's something that you can definitely try. And if you want to maybe track that with some of your labs, it may be something helpful to see how that improves your blood sugar response. And you can also look at supplementation with things like berberine and inositol. Berberine kind of works as like a natural metformin. Metformin is a very common diabetes drug that works through something called the AMPK pathway to help with blood sugar control. And it's just an herb that you take before each meal. Some people don't do well with it. Some people get like nauseous or they don't have like good digestive responses to it. So it's not for everyone, but I would say that's like 1 in 10 people. So for most people, it works really well and it can be a great addition for blood sugar. Inositol is a B-like vitamin. Most people do really well with it. There's generally no issues. It has some benefits to the brain as well to sleep. So there's other benefits outside of just blood sugar, but it's been shown to also improve insulin sensitivity. So help improve that insulin hormone that then influences blood sugar. And both of these are vitamins that we can send you on full script. I would recommend regularly checking your fasting blood glucose, your A1C, and your insulin levels. Generally, it's pretty standard on your physical for there to be blood glucose and A1C. And you can always ask one of our doctors to add on insulin, or if you're working with Romana and myself, then we can always put that into your lab order as well. But it can be really helpful to track those things because insulin levels have been shown to be high for about 8 to 10 years before you start to see issues with blood sugar occur. So if we can get ahead of the curve and we can catch issues with insulin ahead of time, then we're going to have more effectiveness in terms of improving blood sugar long term. A continuous glucose monitor can also be a really helpful data feedback tool. If you have prediabetes or diabetes, this is something that your insurance generally covers and that you can get a prescription for. So that's something you could always ask your doctor as well. Otherwise, it can be something you can purchase, pay out of pocket for. Generally, you get about 10 days worth of use out of it. It attaches to your arm. It doesn't feel like anything in there. And it's basically tracking your blood sugar continuously, all 24 hours of the day, so that you can see how different things like what you eat, your sleep, your exercise, beverages, so on and so forth, all influence your blood sugar. And you can kind of make changes on the fly based off of that data. So it can be a really helpful just biofeedback tool for understanding how your daily decisions are impacting your body and making changes that maybe you wouldn't be able to be motivated to make without having that information. Okay, so that is everything for tonight. I'm going to open it up for any questions. I know there's not many of us here live, but if you have any questions, you can either pop them in the chat box or you can unmute yourself, and I'm happy to answer those for you. Whoops, this is the wrong link, but we will send over the right link in the follow-up email that has the recording for all of the supplement recommendations that we discussed throughout the presentation. And then if you have any individualized questions on the supplements or kind of considerations you want to take into account, you're not sure if something is good for you, then we recommend calling the office, and Romana is currently seeing patients, and she can look through your labs and kind of advise you on individualized recommendations based off your needs. Okay, any questions?
So, Lauren, I have a question.
Yeah.
So the best process would be to go in and get some lab tests done on testosterone and progesterone and have all these measurements made?
Well, if you're already through menopause, then we can assume that your progesterone, estrogen levels are really low.
Right.
So those, like, we don't really need to test for to confirm. It could be helpful to have like your DHEAS levels, your testosterone, your total testosterone, your free testosterone tested, so that you can see, are you someone that's dealing with low androgens, or are you someone that's dealing with high androgens? So that would be, generally we're not going to test for androstenedione and DHT in blood labs, but something like testosterone and DHEAS would be tested. Those would be something very easily that can be tested to see how your levels are currently.
So basically, you're just saying going in and have some of these measurements made.
Yeah. So testing your testosterone, your DHEA, and your sex hormone binding globulins would probably be the most helpful if you suspect that you could have high or low testosterone levels. The estrogen, progesterone, I wouldn't really worry about unless you're in perimenopause. If you're totally past menopause, then they're going to be low.
Right. And there's nothing you can do about them anyways, right?
No, unfortunately, like, there's no going back with the ovaries, kind of done their deed in life. But, some people choose to go like the hormone replacement route. And we have a podcast episode with Dr. Masserman, who's an OBGYN, and he talks about that on that episode. So that would be like a good resource if you want to learn more about that. It's not for everyone, but for some people, it can be a big component to symptom relief.
Okay. And is that test hormone replacement coming up? The video, or we've done it already?
It already published. Yeah.
Okay.
Yeah. So if you go to, like, if you have an Apple or iPhone, if you go to the podcast app,
yeah,
and you type in Nourish MD,
yeah.
Let's see what episode it is. Yeah. So it was published on October 9th, and it is Women's Health with guest Dr. Jay Masserman.
Okay. Because I know there's a lot of issues about conflicting evidence whether hormone replacement causes strokes. I guess they used to say that it did, and now they're changing their mind. So I guess it's isn't it?
It really comes down to like your individual risk factors, and then also the type of hormone replacement therapy you're on. So like a lot of the info that's out there, they're talking about synthetic estrogen and synthetic progesterone, which are very different than you taking like bioidentical estradiol and bioidentical progesterone. So, and I believe we talk about that in the episode with him. But yeah, that's just like a really important piece, is like what type of hormone you're replacing with.
Okay, that's great.
Yeah, it's never going to be the same as like your own, but it's going to be the closest thing. So you want to make sure, because a lot of times people say, oh, estrogen. Well, as I mentioned, estrogen isn't really a thing, right? There's estrogens, but there's 3 types of estrogen. So what we really care about is estradiol, because that's the main one that's having all of the benefits to these systems. So you don't want to be on estriol, for example. You're not going to get those benefits. We want to be on estradiol.
Okay. Very good. And that should give you like better muscle. As you get older, you kind of lose muscles.
Yeah. So estrogen's important in muscle. I would say testosterone is the most important, though.
And you can't do anything about that, testosterone, right?
You can, yeah, because remember that that's the one that is coming mostly from your adrenal glands. So we can actually boost production of testosterone through the adrenal glands if that's an issue. But that's why seeing where your level is first is important, because, you don't want to start on DHEA, for example, if you already have high testosterone levels.
Okay. Wonderful.
Yeah. So hopefully that was helpful.
Very helpful. Thank you. Very good.
Okay, everyone. So we'll be sending out this recording along with that full script link. And then if you have any further questions, please reach out. For those that aren't familiar with our podcast, we post it on Apple, Spotify, and YouTube. So depending on your preference, you can find it any of those places. And you'll just type in Nourish MD, 2 words. And you should be able to kind of find all of the different episodes. We publish 2 episodes per month, 2 to 3. So there's a lot of different ones on there between, what we talked about, the hormone replacement therapy versus allergies and inflammation, so on and so forth.